This one is more related to treating an autoimmune disorder. There are many in dermatology and in other areas of medicine, but there are basic principles that we can learn from this one. So I will use Pemphigus foliaceus as an example about how to manage autoimmune diseases in dogs and cats. So I will talk about PF in dogs, but this can be applied to other conditions in cats and in other species. So let's start with some basic definitions about Pemphigus. So Pemphigus is not a diagnosis. Pemphigus is not a disease. It's a group of diseases. So we say this could be Pemphigus. It's like saying this could be an infection. It could be blastomycosis, or it can be nocardiosis. So it doesn't make a definitive diagnosis. So in fact, Pemphigus is a group of autoimmune skin diseases that are characterized by acantholysis. So acantholysis meaning that there's a loss of cohesion, a breaking of the intercellular bridges in the epidermis. And we know clearly that this is an autoimmune disease because there are autoantibodies against epidermis and specifically against desmosomal proteins. And we see that in the vesicles that we observe during the course of the disease. Pemphigus foliaceus and Pemphigus vulgaris are very old diseases in humans. It has been reported for centuries. But only in 1964 it was, say, observed or reported that they were consequence of antibodies. Until that time, nobody suspected the origin of this horrible disease in humans. In '64, two people, these two doctors, British doctors, reported that in fact, this disease was a consequence of antibodies against the epidermis, and especially against the proteins of the surface of the keratinocytes. And they demonstrated that clearly because they took serum of patients with Pemphigus vulgaris and Pemphigus foliaceus, injected to mice, to newborn mice, and observed the same lesions on the skin, saying, hey, the cause of that are these antibodies. So it was a very clear demonstration that these autoantibodies against these proteins of the surface of the keratinocytes were the origin of this. And then since that time in the 90s, we started to clearly identify each protein targeted in the disease. So we know a lot about Pemphigus foliaceus. It's the most common autoimmune disease in the skin of dogs. We know exactly the protein that is targeted. We know quite a lot about the genetics. So it's very important and it's well characterized. It's not like, for instance, discoid lupus, this disease of the nose that you see frequently. We have no clue what is causing discoid lupus in dogs. We suspect that it's an immune-mediated disease that we can treat with different things, but really, what is the cause of that? Why this dog developed this disease? Not known. In PF, we know a lot. There are different subtypes of Pemphigus, but I think for the practitioner, you have to remember one of these Pemphigus because it's very common in dogs. You don't need to worry about this, simply about this. When I teach my dermatology course in the US or in Barcelona, I tell to the students, you need to know 31 diseases of dogs. 31 in dogs and cats. These are the common diseases that you have to diagnose. If you don't know one of the diseases, you are not a good clinician. But if you ignore disease number 73, this is not a problem. You are not supposed to diagnose Pemphigus legetans. It's a very uncommon disease, it's not well understood. Probably you need to refer the case to someone with more expertise on dermatology. But you are supposed to diagnose well Pemphigus foliaceus because this is a common disease. You are supposed to diagnose dermatitis. You are supposed to diagnose Cushing's disease. You are not supposed to diagnose discoid lupus. You are not supposed to diagnose erythema multiforme because it's too complex for a general practitioner and not so common. So from all the pemphigus of the dog, basically you need to worry about this one, Pemphigus foliaceus. So what is Pemphigus foliaceus? Well, it's the most common pemphigus of the dog, the most common autoimmune disease of the dog. You see many cases of PF. In many cases, I think it's misdiagnosed as pyoderma or other conditions or diseases. And this is the consequence of the production of autoantibodies against one protein of the epidermis called desmocollin in dogs. It's different in humans. In most cases, PF is idiopathic. So when the owners ask you, why is my dog developing this horrible disease? You say, we don't know. We know that there is a genetic predisposition. I did in Boston a study of 100 cases of Pemphigus foliaceus, so 100 cases of dogs with PF. 25% of them, 1/4, had another immune-mediated disease. So probably there is a predisposition to develop multiple autoimmune disorders. And Pemphigus is one of the manifestations, but many had keratoconjunctivitis like Zika, or had immune-mediated polyarthropathy, or immune-mediated thrombocytopenia, immune-mediated anemia. So these dogs are predisposed to have autoimmune diseases. So the immune system is not working adequately. So don't be surprised if one of these dogs has also another disease, because the predisposition is not specific for PF, it's for autoimmune diseases. Also, we know that in some cases they are drug associated, meaning that a drug triggers a process or causes a process. So in some cases we call that this is drug induced because a drug can cause pemphigus, or in some others the drug simply triggers the process. The dog is predisposed, but because it was an antibiotic treatment, this started the process of the pemphigus. Probably you know very well of these two products that have been used for fleas and ticks in the past. They trigger episodes of PF in dogs and were removed from the market because many reports of dogs developing Pemphigus foliaceus after the treatment with these two treatments, with Certifec and Promeris. And then there are many reports in the literature of antibiotics causing PF. So one thing that you do at the beginning when you have a case of suspected Pemphigus foliaceus is double check the history of medication of this patient. So what about the clinical presentation? You can diagnose a PF in any dog, any age, any breed. Typically, they are middle-aged dogs, 4 to 8 years, with low pruritus. They are not itchy dogs. They are not dogs that come to you for a history of scratching for years, that you have seen in atopic dermatitis. And some breeds are clearly predisposed. The Akita, the typically Chow, the Dachshund, Doberman Pinscher. And you have to suspect Pemphigus foliaceus when your patient presents one of these three things, presentations. One, depigmentation, erosions, ulcers, and crust on the nose, eyes, and ears. Okay, this facial depigmentation, erosion, ulcers, and crust. Two, pustules and epidermal collarettes all over the body, usually non-responding to antibiotics, and when you do a cytology, you don't see coxine. Or footpad hyperkeratosis with inflammation. Your patient can have 1, 2, 3, 2 of them, or all 3. If you have a patient with the 3 presentations, so meaning crusts on the face, pustules on the body, and hyperkeratosis, the diagnosis is very easy. It only needs just say, I have Pemphigus foliaceus, please diagnose me. In some cases, when they come to you, they only present with pustules or with the hyperkeratosis of the foot pads, and then you need to be a little bit more careful to reach a diagnosis. So let's see a couple of patients just to get used to them. So this is a very classic, easy case. crusting on the nose, around the eyes, some crusting and pustules all over the body. You see the lesions are moving caudally, and you see here there are some cracks. This is the prepuce, also with erosions, tiny pustules and vesicles here. This is the same dog with the crusting, with the eyes. These are the foot pads. They are not too bad on this one. There's some hyperkeratosis here, but you will see worse cases than this. This is a much worse case. In this case, we suspect a PF, but this is also with a secondary infection. You do a cytology, you see many bacteria, you treat with an antibiotic, and this is the real PF of the same patient. You clear the infection, but here, this is something that doesn't disappear with the antibiotic. And this is the same dog. You see the hyperkeratosis, the crusting, the fissures on the foot pad, the paronychia, the inflammation around the nail bed. Very typical of PF. So this is a case that, looking at this, this will be a PF case. There's another one. This Sharpie said that mainly pustules all over the body. Not too much crusting of the face, is basically this. If you are a good observer and a good clinician, looking at these pustules, you see these are not the pustules that I see in pyoderma. They are more flat, they are more irregular. So you see that they are more hyperepic around. So these are not the typical rounded, yellow pustules that we see in pyoderma. They are more flat, irregular in the limits. You see them. Some of them extend over several hair follicles. You see the Pemphigus foliaceus pustule. Flattened, irregular, not so turgent. This is another dog with PF. Yeah, docents, they are very, very prevalent in the clinic. You see that the big pustules on the abdomen. See. Some are crusted. And this is a very severe, this is a drug-induced PF, and it was very severe in presentation with a lot of inflammation on the foot pads and a generalized pustular. I marked here a few sites where I'm going to take a biopsy. You see, these are the pocket pustules, and these are the foot pads in PF. Very severely inflamed, crusted, and with fissures. Very painful. Some dogs are really lame. And taking the samples, you see the primary lesion here, the vesical pustule. So this is the clinical presentation. The diagnosis is very easy. If you know the clinical signs, if you know the disease, if you know how to take a cytology sample and a biopsy, you will reach a diagnosis soon. In the past, it was recommended to use immunological tests. Now we know that it's not necessary. Simply use a good pathologist, do a good cytology. The cytology of the pustule of the vesicles will show this. Many neutrophils. In some cases, you will see also eosinophils. The neutrophils are not degenerated, not very acutely degenerated with DNA strands, with many cocci. You don't see bacteria, it's clean. And then you will see these large cells that are acantholytic cells, some of them together in small clusters of 2, 3 cells and drafts of cells. So this is very suspicious of PF. Don't do a diagnosis based only on that. This is helpful. Indicates you are on the right path. This looks like a PF, but you need to do a biopsy. You have to consider that this is also a very severe disease that will need a treatment lifelong, and you need to have a paper with a good diagnosis, not just an impression and say, well, I think I saw a few cells, there was a lot. No. Do a proper diagnosis, send the sample to a pathologist, get a good report. In case that there is some doubt or there is no improvement with the treatment, you can always talk to her and say, hey, the dog is not improving. Are you sure that this was a PF? I'm doing the right thing because I'm immunosuppressing this dog and I don't see an improvement. So I think it's better. I never start a treatment for PF based only on cytology. And I have been doing cytology for many years, so I have some experience with cytology and I don't trust it. So the diagnosis is based on the biopsy. The typical lesion is a pustule which is intracorneal, and you see here that usually is under the stratum corneum or stratum granulosum, and you see these rafts of cantholitic cells, which are very characteristic in some areas, big clusters of epithelial cells. You see some eosinophils also in the vesicles. So for the pathologist, it's a very easy diagnosis. So when you have a diagnosis of PF, then begins your challenge. I always tell to my residents that they will become a dermatologist when they are able to maintain alive a dog with a diagnosis of PF longer than 1 year. So when they are able to make a diagnosis, start a treatment, and keep the dog alive longer than 1 year, I say, you are a good dermatologist, you can do that. Because the challenge is not doing a diagnosis. If you can take a good sample and you know the disease, you are supposed to diagnose the disease. The challenge is to keep this dog alive for many years. And then you need to adjust pretty well the treatment. The theory is easy. It's easy as in many autoimmune diseases. We use the treatment in two phases. Phase 1, what we call induction, that is usually a few weeks, usually more than 2 weeks, say between 2 and 6, 8 weeks. We call this induction phase because we control the clinical signs doing a very strong treatment. We stop the autoimmune disease and immunosuppress the patient. We can do this only with prednisone. In some cases, you can try, use only prednisone, and more or less 2 milligrams per kg a day, or more commonly, you can use a combination of prednisone and ephedrine, which is the standard treatment. When the disease is under control and you see a clear improvement, then you start to taper this dose, and then you reach the lowest dose that maintain the dog lifelong under control. This is easy to say, but as you will see, it's not so easy to do. Especially it's not so easy to keep the dog alive 3 years, 4 years. So I really like when they show me a dog with PF living 4 years. There are several cases, a series of cases published, and 50–60% of dogs are euthanized because they do not respond to the treatment. But in fact, it's because the treatment has not been good enough. So you can begin with prednisone monotherapy only in mild cases. This was a drug-induced case of PF, and then responded very well only to prednisone. It's an easy case. According to the literature, maybe 30% of PF cases can be managed initially only with prednisone. So if you think that the case is very mild, or maybe it's triggered by a drug, you can try to use only prednisone, and you avoid side effects and complications of polytherapy. And that's, you see the dog, of course, is heavier because it has been about 2 months on prednisone and has gained some weight, but it's doing much better. The standard treatment for patients like this is one of my patients of PF, this is a very severe case of PF, is a combination of prednisone and ephedrine. That's the classical treatment. You see the dog have lesions on the face, around the eyes, all over the body, foot pads. This is a poor dog. You see the legs. You see the foot pads with this inflammation, very severe. And one thing that we do when you manage this patient, and it's very important, is the day of the biopsy, do a blood work. You will need that. This will be your reference. You need to know how was the dog at the beginning of the treatment, because you will follow the changes. This dog, for instance, had already high alkaline phosphatase. The referee vet has been treating this with different doses of prednisone just to see how it responds. This doesn't help. What we are doing is we start to damage the liver of these patients that will need long-term therapy. So when we give a treatment, a shot of steroids, and just to see if we improve, in fact, we are reducing the probabilities to survive of this dog, because we're starting to create some damage of the liver. Here you see a few changes. So this gamma GT is high, this alkaline phosphatase is high. We know that this is probably linked to the steroid given by the referee vet at the beginning. But this one, for instance, the LT, is also double of the upper limit. This is not related to the steroid, or is not inductible enzyme, is more damage of the hepatocyte. So we have a bad thing. We could manage this dog. The treatment was not too bad. You see how it was improving with the treatment. And yeah, this is the dog living at home. I think it was 1 or 2 years later. You see that they had 2 Labradors. You know clearly which one is the dog with PF, because you see the severe atrophy, and they were very similar. And now the dog is doing relatively well, but you see the atrophy of the muscles, then you see that this is much more thinner. So it has an impact to have a lifelong therapy with steroids. This is another case of treatment with the classic combination of pred-azathioprine. You have seen this dog at the beginning with the pustules all over the body. You see that this is just 10 days after the induction with pred-azathioprine. See the lesions are drying, it's improving quickly. This is 5 weeks, the dog is doing much better. So in some cases they do relatively well. This dog, Harley, had pancreatitis, and we had to stop the treatment, change to cyclosporin. So this dog had a crisis and survived, and now is doing relatively well. But I will show you an example of how to adapt the treatment to the situation, to the different situation with this patient, which was Milo, that you have seen at the beginning. Milo is 7 years old. Sent it to the vet because of skin lesions. The vet tried some prednisone at low dose, not pruritic, a little bit pruritic. We did a biopsy, we diagnosed PF, you have seen the dog, he has lesions all over the body. See here. And then you will see exactly what we do step by step to control this PF. Here you see the dog with the lesions. So this is the blood work when we started the treatment. This is the baseline. Neutrophils 13,000, lymphocytes 1,000. Remember that 1,000 is the lower limit of lymphocytes. I don't want my patients to be below 1,000 lymphocytes. More or less, this is a rule that you have to keep in mind. If you are below 1,000, you start to be lymphopenic. Here at the beginning was at the limit, had some eosinophils. Alkaline ALT was a little bit higher, not terribly, so not too much damage of the liver. Alkaline phosphatase was 470, high, probably because it has been treated with some steroids in the past, just to, by the urea analysis was with normal limits, gamma GT a little bit high together with the alkaline phosphatase. So this was my starting treatment, the standard one. So the dog weighs approximately 30 kilograms. So I'm giving 1 milligram per kg in the morning, 1 in the afternoon, so 2 milligrams. I don't go very high. You don't need to go 4 milligrams. Or the book says sometimes 4 to 6. Don't do this. You will kill your patients. They will never survive 2 years with this dose. So be more careful. And I start azathioprine. I go close to 2 milligrams our starting dose. So There are tablets of 50 milligrams. I think here's the same. That's 50 milligrams at the time.
No, 100.
It's 100. So you with half of this, and 100. And I usually say, we start this, come in 7 to 10 days for my first recheck. Because ethothioprine, in some cases, causes very fast side effects. Bone marrow damage, liver damage. So my first control is after 7 to 10 days to see that things are not becoming crazy. So this is the dog after 1 week, the first recheck. It's better. You see that the nose is better. The lesions are drying. If you don't believe me that it's better, this is 1 week ago, 8 days ago, and 1 week later. It's improving. You don't think so? It's a little bit better here than here. It's drying, so it's good. This is the blood work. Still pretty good. We have, again, high neutrophil, but it's not too bad. The eosinophils start to go down. Lymphocytes remain on 1,000. I'm happy, not too severe lymphopenia. ALT, it's coming up high. So we are just creating some hepatotoxicity. Alkaline phosphatase is 4,000. I don't like this. The liver is producing a lot of alkaline phosphatase. Gamma GT is now close to 200. So the biliary ducts are also secreting that. So bad news, the cholesterol is going up. So I have signs of that. And this is 1 week, has been 8 days on treatment. I have to treat this dog lifelong. And after 1 week, he's doing this. So I have to change things. So my hypothesis now is maybe ethothioprine is causing this, because it has changed so dramatically. I will continue with the prednisone, withdraw ethothioprine to see what happens, and recheck again in 7 days to see how it's doing and to see if there's clinical improvement. So the vet called me in 7 days and said, dog is doing much better. It's improving. See, the lesions are dry, so these are at home. But the blood work is not good. Say, okay, send me the so lymphocytes go down, neutrophils still going up, eosinophils down, ALT 700, so it's damage of the liver. Alkaline phosphatase is 9,800, so that's good, pretty high. The owner is very happy, saying the doctor is working very well, so I see my dog improving, I'm happy. And cholesterol is 400, so I say, okay, so I have stopped the ethothioprine. I cannot blame ethothioprine. It's prednisone that is continuing doing this damage. So I need to start tapering the prednisone quickly. Yeah. The owner is happy, so I say, no, it's going very well. I say, yeah, it's very well, but with 10,000 of alkaline phosphatase, you will die soon of other things. So I start tapering the prednisone to 30 milligrams once a day for 7 days, and then to every other day. The dog was almost in remission, so clinically. So I did it. So let's say. So the owner say, no, doctor, now you know, when you suggested to reduce the prednisone, the dog is started to flare. And when I went to every other day, the disease came back immediately, again bad. So the liver values, when they did the blood work, it's better. So I think, well, this dog needs to be on steroids, high dose to be under control. Sometimes a trick that I use is to change the steroid. You know that some steroids are less damaging than the other. So one first thing that I did is to change to Medrol, which is methylprednisolone, and no change. So the situation was more or less the same. So when they try to reduce the dose of prednisone, the legs that were beautifully pink and healing, when I tried to reduce the steroid, they The good news is that when you do that, the values of the alkaline phosphatase and the level, they go down. So you have to select your devil. You want to have a skin lesions or liver disease. What is your choice? So the alternative in these cases, this is a very common situation. I would say 50% of dogs with PF, when you manage them, you go over these phases. I always tell to the owners, if you are with me along the first 2 or 3 months, we will be able to cure your dog or control your dog. If you, during these phases, say, okay, this is impossible, the dog will do well, then no. But if you keep doing what I'm suggesting, we will be over that. I know that we have seen horrible things here. Liver damage, big dose of that, skin lesions, and I know that I'm not controlling this patient. But if they keep the faith on me, we will be able to go over that and cure this dog. So the situation is that I know at this point that with high doses of prednisone, I control the dog, but the side effects are too heavy. When I taper the dose, the disease flares, but the liver starts to improve. So what I have to do, I have to combine prednisone with another drug to be able to reduce the prednisone and keep the disease under control. And these are the choices that we have. We try already azathioprine. Azathioprine has some side effects on the liver, probably is not the best alternative. Chlorambucil, I don't know if you have here. Chlorambucil, you have here. And it's affordable in price?
Yes.
Yeah. Will be an option. In the US, this is an American dog. It's very expensive now, chlorambucil, because it's $1,000, so that's not an option on the table. We can use mofetyl mycophenolate. That's another immunosuppressant that we can combine, and we can use cyclosporine. So we had a few options to play with. I started with mycophenolate. Mofetyl mycophenolate is an immunosuppressive drug that cannot be used alone. It's not strong enough to be used alone on PF. But together with the steroids, in some cases, helps to do what I want to do. I want to reduce the dose of steroids. So, and the side effects are not hepatotoxicity. They usually present diarrhea, vomiting. So I like it. It's a different type of side effect. We need to monitorize and do that. So we started with a low dose of mofetyl mycophenolate, and we increased progressively the dose. And then what I suggest is go over this to the final dose of 500 twice a day, and then we will start tapering again the prednisone, because I don't want to use so much prednisone. So the owners report, the dog is doing well, but when I taper the prednisone, the disease appears again. It's happy. This is on the coast, on the Cape Cod, on Boston. It's playing on the beach. But they say, dog, every time that I go down with the prednisone, even being on this second drug, the dog flares and the disease reappears. What can we do? Try the next one. So don't give up. Don't give up. So alternative. Let's move to the next. Cyclosporine is also a good option. Cyclosporine is not hepatotoxic, has different toxicity. We need to use it at relatively high dose, in this case 7 to 10 milligrams per day, and then taper. And combined with prednisone, help to reduce the dose of prednisone. So this is what we started to do. And Milo responded well to this combination. He's on 200 milligrams of cyclosporine, and we are repeating the blood work, and he's responding pretty well to this treatment. So finally, after going azathioprine, mycophenolate, and Medrol, and now cyclosporine, he's doing relatively well. Here you see Milo. This is approximately 1 year after treatment. There is some atrophy of the muscles. You see, there is still some lesions here. And here you see, 1 year later, at the recheck, you see Milo is doing, it's becoming older, but it's well controlled at low dose of prednisone and cyclosporin alternating days. And that's not too bad for living 2 or 3 years on with a PF. So, of course, you need to monitorize every 4 to 6 months these dogs, do all the controls, continue with the treatment, adjust the dose, but he's living, and that's, the owners are happy, and they remember the time, the first 3-4 months, when we were struggling with this managing. But when you find something that works for this dog, then you solve it, okay? So of course they need to be with you, but if they do this, at the end you treat this dog and he's having a normal life. So this is the theory, but the reality it's different. You need to adjust much more and find an adequate and a precise treatment for each patient. When you treat patients with PF, you can have 2 types of problems. Problem 1 is that the remission cannot be induced. So you start the treatment and the dog is not improving enough. So we are not worried about the long term. It's even on the short term. The disease is not responding to a treatment. If this happens, then you don't need to change the treatment. What you can do is increase a little bit the dose of prednisone to 3 milligrams. Some dogs need a little bit more. You can try other steroids. Some dogs do better on dexamethasone than prednisone, so try to reach the remission with another steroid. If you are using only a steroid, add ethopioprin. And for the induction of the remission, you can use intravenous immunoglobulins. This is an expensive treatment, cannot be used long term, but sometimes for inducing the remission helps. I don't use it very frequently because it costs a few thousand of dollars, and this is what the one that we use is a human immunoglobulin, and it's a treatment that you use 3 days, and this one was of my patients treated with immunoglobulins. It was almost impossible to induce remission to this guy. And also was a dog with cardiac issues, so we could not go very high with the steroids because we were creating some heart issues, failure. So the only, and you see how bad was the PF on this dog. So the only thing is one. So the only thing that we could do on this patient was to use intravenous immunoglobulins. Had the food packs here, you see. So you need to put the dog in the hospital and 3 days to give a dose of immunoglobulin, still a total dose of 1.5 milligrams per kg, and then you induce the remission. This costs a few thousand, but then from the remission you can continue with other treatments to maintain the dog. If the problem is when you try to maintain the dose, or maintain the dog under remission, like Milo, then usually what you are supposed to do is to find a combination of drugs that can keep the dog under remission. So if the problem is that I'm able to induce the remission with the steroids, the problem is that the dog needs this high dose forever, and I cannot give it because it's going to develop pancreatitis or severe side effects or calcinosis cutis or whatever, then remember that you need to combine the steroid with another drug. Try ethopioprin. If not working, try cyclosporin. In my hands, cyclosporin is very effective, a high dose together with cyclosporin in PF cases, and is a good alternative if the owners can afford that to control these patients. And then with that, you can go and move for the long term, doing every 4 months a good control of the blood work, urine, and chemistry. Okay? And I think this is the last one. Just happy to answer any question that you could have about PF. was disappeared. Yeah, lomustine is another option. I have only tried it once and did relatively well. Has side effects, but it's something that we can try. You can also maybe try apoquel at very high doses. That's another possibility that we could do. So there are some other options to try, but I will say that for most of the cases, I think if you are able to use well steroids, ephethioprin and cyclosporin, you cover 90% of the cases of PF. For the rest, you can send to Ana Maria, to some specialists, just to show that, to try different things. And with these three well used, that's good. Another thing that I think that it's important with PF is to explain to the owners that there will be a difficult time at the beginning in most of the cases. They need to be prepared to go over that, do the blood work, do the urine analysis, adjust it, because it takes some time. We cannot fix things like this. If they are ready to work with us, we will fix the patient.